Good morning, everybody. I'm with Alessandra Laricchia. Just briefly, Marco is our technician, Elisa is our nurse, and Arif is the fellow. We are approaching LED PCI, ostial proximal LED PCI. If you agree, we can go on with a clinical history briefly of the patients.
Yes,
Alessandra?
maybe before I tell you who do we have on our panel here as chair, we have Dr. Vijan, Dr. Dal, and Marco Roffi, myself. So please go ahead.
Morning, everybody.
Good morning.
Morning.
So here we have a young female patient, 53 years old. She is a previous smoker with some dyslipidemia, mild, and a subclinical hypothyroidism. She's suffering from few months of effort angina with typical chest pain. And for this reason, she underwent some examinations, including a transthoracic echocardiography that was normal lab tests, and she also underwent a stress test, HEG stress test, that however was inconclusive for HEG modifications. So she came to do coronary angiography. At the admission, we can show just her baseline ECG, that is quite normal. Okay.
Okay, so the patient was referred from another hospital. They sent us just some pictures of the previous angiogram. Now we can see our angiogram, the angiogram that we have performed just now. Thanks, Marco. So this is the caudal right view. You can see there is a tight lesion in the proximal LED. From this angiogram, it doesn't seem that is involved the left main. It seems quite I would say, easy to say that we can treat this lesion without involving the left main, just stenting from the ostial LED. Next.
Maybe I just ask the chairs. Any comments on this? Everybody agrees?
Let's just see an eleocaudal.
Yes, we need an additional, let's say, image.
So
to make sure.
that's the cranial view. From the previous angiogram, from the other hospital, there was some concern about the ostium of the diagonal, but here doesn't seem significant. Next, and you can see here the caudal view. Yeah, seems that we have enough space.
There's enough space.
The left main. Yes. So very easy the approach in this case. We are already predilated because after wiring there was some, because of the subocclusion, there was some limitation in the flow, so we predilated with a trionon compliant balloon, high pressure. That's the result after the lesion preparation. Now our plan is to perform the HIVUS that we routinely do in case of ostial and proximal vessel when we have large vessel, just to avoid malapposition. I wouldn't say in this case under expansion because the lesion seems well prepared, at least angiographically, just after a trio balloon.
Yes,
so,
and this will give you an additional, will confirm you in your strategy to flare the ostium.
How many in the audience would actually do that, do a IVUS now before stenting on a routine basis? I don't think anybody. That's the difference in practice.
Yeah, but Dr. Colombo doesn't use too much of IVUS either. Anyway.
I just pull back a bit the catheter. We were too much selective.
So again, the main purpose for you right now is sizing. Is this correct?
Yeah, I would say sizing, and just to be sure also with the HIVUS that there is no plaque in the left main, okay. And there is just disease in the LED. So we can start the pullback. Arif, if you want to comment, it seems that here we have a quite healthy vessel. Here is a 2.5 vessel. No disease at all. Here the diagonal is coming. Seems that we have enough space to land before the diagonal.
Yes, for sure.
Please a bookmark here. Here seems a 325 vessel. Here we have the plaque, is a soft plaque.
Yeah. Okay,
Doesn't seem fibrotic at all. Here the vessel becomes quite bigger, is a 4O vessel, and here the left main, so we can stop here. Please have a look together, Arif. Let's start from the ostium of the LAD.
Okay.
So there was some plaque also in the left main. Obviously, the question is,
Yeah, but I think...
what degree of plaque is this relevant?
Go more distal, please. Distal. Okay, that's the ostium of the left main. Yeah, seems that we have also here a lot of plaque. Let's play from here. Okay, and there is a huge mismatch with the left main. Still disease in the left main. So which is your suggestion to manage this case? Would you avoid the left main? Would you just protrude a bit in the left main just to be sure that we cover all the disease, or would you prefer to land the ostial LAD, so landing in a disease segment? Let's pull back.
So personally, I think I would go into the left main because the disease is coming clearly up to the ostium, and then with mild disease in the left main itself, the origin of the circumflex is free, so very little danger there.
So what about the other panelists?
Any other comments?
I think it's always very, very difficult to be precise at the ostium of the LAD or any, and you invariably either miss or maybe a couple of strengths come in. Going to do it, I think, come all the way into the left main, cover the ostium of the circumflex. It's normal, so that should not be a problem. And if it does appear to be pinched, you can just do a kissing and move the stent struts out of the way.
Okay, so we have here the measure of the distal reference vessel. Can we have a look again, Arif? The distal one. So it is a 3.5 to 3.5 vessel, so we can go with the 3.5. Let's see where we can land into the left main. If we need to have more acquisition of the left main, we can go with the IBUS again.
You want to land in the left main?
Yeah. Yeah, because I agree there is still plaque, so I think it's better to cover it.
Go into the left main, I think.
So we normally cover from less than 50% plaque burden to less than 50% plaque burden. You're not likely to find a totally plaque-free area at any point. So I can't see 50% plaque burden in the left main.
Okay, let's just
so you would position it ostially?
I'm actually not very clear about the image. That's why I withheld my comments.
So your next step is what now?
Yeah, and I'm just looking better at the left main because I, before
No, because by any of the criteria that we have used, or the XPL or whatever, so we just having plaque does not mean that we ought to place a stent.
Yeah, so here we have still plaque, I would say a lot. We are at the proximal LAD, a lot of plaque.
That is acceptable. Yeah.
Here still a lot of plaque.
That's correct. This needs to be treated.
Here I would say still a lot of plaque.
Yes.
And now still plaque, maybe is less than 50%, but here we are in the left main.
So what's the diameter of the left main here? 1, 2.
Bookmark here.
5. 5.
Okay, stop, and then let's give some measure of the left main.
So that's why I actually wanted to see an LAO caudal, a spider view, because we wanted to also ascertain the angle at which the circumflex is taking off, which I was not very clear because we could not see that.
Probably we have already done a spider view that we have a look. Come back.
So the left main measurements are coming out at 4 millimeters.
Look more.
I'll play the IVUS images again, the last run we just did now.
So I think we can go with 3.5 18 stent with the idea to land in the left main, then to perform a pot with a 4 balloon, semi-compliant, very short balloon, and then let's recross the. We can decide later, but probably we are going to.
So are you going to cover the left main ostium here?
No, absolutely. I will land the body of the
Can you
left
just show
main.
us the spider if you have one?
Yeah, can we have a look again at the spider view? Okay, let's do one now. Piccolino. Okay.
Yeah, this one.
Healthy.
My left hand looks healthy here.
This is disease.
What do you think?
I am not sure whether I would like to pull the stent into the left main because the bulk of the disease is in the osteoproximal LAD, and I think there is a reasonably good angle, which is about 90 degrees. So I think that we can land with a radiopaque stent with probably the marker on the proximal strut. We can probably do a pure osteal placement.
Let's.
We can have a. We can ask the other colleagues. Suresh, what do you think?
Let's have a look again.
Maybe we can make a poll, just a poll. So let's say.
How many? Yeah.
Play.
Yes. How many people will stand the left main? How many people will just go in the LAD ostium? So the vast majority of the audience is voting for LAD ostium.
Okay, let's again the HIVUS. We are looking again at the HIVUS. Let's go a bit more distal, sorry. Let's play from here again. So here still a lot of plaque.
So you want to do anyway a minimal protrusion into because the lesion is going really.
Yeah, becomes better.
I mean,
still plaque. Yeah. I think. As you can see, is a case in which we can discuss about the strategy because it's not completely healthy, the ostium of the left main, the LAD. I think what is important, whatever is the strategy, is to be sure that we have to reach a good result and to perform the HIVUS also after. So looking again at the HIVUS now, I agree with the colleague, and I also would choose to go with the very minimal protrusion in the left main to be sure that I cover all the ostium of the LAD without so much protrusion, just 1 to 2 millimeters, just to be sure that I cover all the disease in the LAD. So let's do a measure of the stent. Probably is a 3.5, 15 millimeter, but just have a look again, and then we can go. I think we can switch again to Professor Colombo lab, and then we will see again after the stenting with the IVUS check.
Okay.
Perfect.
Yeah.
So Dr. Giannini, we are back to you.
Okay, so you can see here, so as we said, we place a 3.5 12 millimeter. This is the cranial view before the stenting. We are quite sure that we do not touch the diagonal from this view. Then the caudal view. This is the angiogram just before the stenting. We place just as marker a balloon in the side branch. Go back, please. You can see here there is already some spasm in the circ. Huh?
Exactly.
Okay, this is just before the stenting. Next. We already post-dilated with the 3.5 12 non-compliant balloon. And now we are doing the HIVUS.
So for the time being,
we already did the cranial view. We already did the cranial view. We are ready with the HIVUS, so I suggest to go with the HIVUS and then to do another caudal view to see how is the ostium of the circ. Okay, let's go. Here we are just a bit distal to the diagonal. Okay, that's the diagonal. Here we have the stent, no edge dissection. Here seems quite well expanded. This is circular. A lot of crushed plaque, especially here. Okay, stop here and then let's have a look again at the ostium of the lady just to see that there is almost no protrusion in the left main and we cover all the ostium of the lady. You can see here again.
Tell us again the size and the pressure of the inflation.
Okay, the inflation at 14 atmosphere, and then we went with the 3.5 non-compliant balloon at 18 atmosphere. Are ready. Go back with the IVUS.
So the positioning looks very good to me. So any comments on the size of the ostium of the lady?
No, I think we've nailed we got the point which we wanted. There is some plaque at the ostium which has not been touched. There was a little gap, and I think the circ is going to be clean. So we have not come into the left main, which is quite satisfactory for an anatomy like this.
Let's give some nitrates. Check. Happy? Check. Check again.
So do you have a left radial axis here?
Yeah, it's, okay. So let's to engage. Stiff part of the wire. It was not easy at the beginning to re-engage this left main. What do you think about the expansion of the stent? It's enough at 3.5? I think it's enough. But
yeah, what is the MLA which has been achieved? If we can have an idea with I think it looks all right, but if we know the MLA, we'll know whether we.
Check.
The MSA, if we can calculate.
Okay, let's do the schedule view.
Yeah, perfect.
Looks good.
Perfect.
So I think it's fine, it's fine. I wouldn't go with the 4-on non-compliant for the post-dilatation. We saw that it's not completely well expanded, but there is just mild under-expansion at the ostium. We didn't protrude in the left main. The circ seems good to me.
Yeah, good, yeah.
Let's do also cranial view. Okay.
And it's a
looks good.
ostium of the diagonal, so that's good.
Okay.
If you can see here, distally we've got 6.98 millimeters.
Yeah.
In the middle of the stent, mid 6.4, and proximally 6.4 again. So that's the minimum stent area that we have.
Okay.
6.4 is This is a 3.0 stent or a 3.5 stent?
Is it 3.5? 3.5.
6.4 is okay.
We can also go with the, probably we can try to go with the 3.5.
You
at
take a
higher-
3.5 and go higher pressure.
28
to-
atmosphere, and let's do the highest to see the final check.
Yeah.
Okay.
Perfect. So maybe in the meantime,
Absolutely. In the meantime, we can switch, yeah,
to
Kaplan?
the other lab, see what Antonio is doing.
Okay, so we post-dilated with a 3.5 at 18 atmosphere, 24 atmosphere. We can see together the IVUS. I think you can see it.
Yeah, now it
That
looks
was
even
the
better.
distal part of the stent was already well expanded.
Yep.
And we are here in the middle, and I think here we had an improvement.
So I'm sure the MSA is over 9 now.
Yeah. Harif, how is, which is the minimal stent area now? No, just, okay, fine.
Perfect.
That's the ostium. So we went from before we had 6.37, 6.4,
Okay.
and now at the proximal edge of the stent, we have
8 point.
So I told you
yeah,
it will
okay.
be around 9. Well
We
Yeah.
can see also the angiogram. So you can see this is the cranial view, the final one, and the caudal view, and the circuit's fine. Okay.
Perfect.
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 So excellent case. Congratulations to you and
So
your
many
team.
thanks.
Excellent.
Thank you. Thank you very much, everybody.
So thank you, Cotignola, and continue with the good work. Thank you. Have a good day.